Please take a seat as soon as possible. We'll get started. So welcome. I'm John Stride, the current president of the City Club of Portland. And we welcome you to our monthly Friday forum. And I'm particularly delighted to welcome you to this forum that we are presenting in collaboration with the Oregon Health Forum, which has been a wonderful partner for us in these programs. It's my honor and an honor for City Club and the Oregon Health Forum to be joined by the esteemed panelists Rachel Prusak, Jack Friedman, and Dr. Tony German, and along with our moderator, Bill Kramer, for this conversation. Before we begin, just take a moment to silence your cell phones. Thank you. Now, just a quick word about the City Club of Portland. Our mission is to inform our members and the community on public matters through producing nonpartisan public forums, debates, and research that informs them about elections and public policy. City Club is committed to providing a space for civic dialogue that encourages respectful discussions and positive solutions. City Club members are the ones who provide the ideas, lead our conversations, conduct our research, and plan our programs that address issues important to our community. Members' dues and donations make it possible for us to provide forums like this free to the public. We have several events coming up that I'd like to tell you about. And you can see more by going to our website at pdxcityclub.org. And I believe it's being shown on our screen. City Club welcomes everyone who is interested and cares about our region. If you join today, you can take $40 off your annual membership by using the discount code NEW40, as it's shown there. We also don't want our City Club dues to be a barrier to anyone in joining City Club, so we've implemented a dues assistance program. And if you're interested in that, please email us at the City Club. All of our events are made possible by our sponsors. I want to give a special thanks to AARP Oregon, Hospital Association of Oregon, the Don Sterling Fund of the Oregon Community Foundation, Tonkin Torp, and Fight Against Sex Trafficking. We also want to thank Oregon Health Forum's annual sponsors for making events like this possible: the Hetherington Foundation for Innovation and Education in Healthcare, and Care Oregon. And lastly, we thank today's sponsor, Oregon Physicians for National Health Program, and Baker Tilly. Please join me in thanking these sponsors. And finally, a thanks to the producers of today's program, Portland City Club Program Committee members, Sam Metz and Shoshana Baird, as well as our Communications Director, Kayla Kennett, for their support here today. Thank you. And now, an exciting announcement for you from our partner, Oregon Health Forum. I invite to the podium Howard Klink, a member of the Executive Committee for the Oregon Health Forum Board, with some news to share with you.
Thank you, John. I want to first say that the Oregon Health Forum and the Lund Report really values this important partnership with the City Club. It gives us an opportunity to air issues and bring together people in a way that really raises the level of education and awareness in the community about important healthcare issues. Before we get started, I want to share some breaking and positive news. The Oregon Health Forum is entering a new phase of impact. We're building on our the legacy, tenacious legacy, of our late founder, Diane Lunt Musicant, at a pivotal moment in healthcare and healthcare policy for Oregon, Southwest Washington, and the nation. The announcement is that we've hired Erin Hoover Barnett as our executive director. We just did that last week. Right here. She's going to be up in a few minutes, so you'll hear directly from her. As executive director to provide leadership for our talented Oregon Health Forum team, and at the Lund Report, where Nick Budnick will remain a co-leader as well as editor-in-chief of the news team. And they are providing, I will say, the most in-depth and comprehensive coverage of the healthcare sector in the region. And I think Nick is here as well somewhere. He doesn't like to stand up, but he's way back there. So just a few words about Erin for a minute. Many of you know Erin. She spent nearly 20 years with the Oregonian covering such relevant topics as health, elder, and end-of-life care, the pain medicine debate, death with dignity, the Oregon Board of Medical Examiners. She was a Neiman Journalism Fellow at Harvard, and she and a colleague were Pulitzer Prize finalists in 2005 for a series on the meth epidemic. Erin then shifted to communications, spending 8 years on the front lines of social determinants of health, student achievement and health at Portland Public Schools. Then she transitioned to OHSU for 9 years, first as communication director in the School of Medicine, and in her last year as strategist for health economist John McConnell at the OHSU Center for Health Systems Effectiveness. As soon as we began talking with Erin, we were struck by her dynamism, compassion, her extraordinary credentials and suitability for this job, and highly relevant and professional and life experience that she will now bring to the curation of the timely and pace-setting forums that serve us well. The forum and the Lund Report were really, really fortunate to have hired Erin, and we are very, very happy to have her join the team. I'm going to introduce her, and she's going to tell you a little bit more.
Hi, I hate standing behind podiums. I'm Erin Hoover Barnett. I'm so delighted to be here. I'm extremely honored. Now that you know my whole resume, you know that I must be right around 100 years old, right? Definitely felt like that sometimes, but it all in interesting ways seem to be pointing towards this role, and I'm delighted. I want to say thank you to Howard, to the board that hired me, to City Club, to people like Bobby Regan, who I have followed around in my career, to our panel. And I also want to recognize at the back of the room Kim Crosby, who is our Director of Operations at the Forum and is already my right arm. She's okay. Thank you. So just super briefly, I just want to say, you know, the point of the Oregon Health Forum is to bring people together who are passionate and interested in areas of health and health policy. It could not be more important than it is right now. And not all of you maybe have been subscribers to the Health Forum or the Lund Report, but you're here for City Club, and we want you to feel welcome under our tent as well. We are very fortunate to have a very important benefactor by the name of Jeff Hetherington, who is here in the audience. And he wanted to stay incognito, so I just busted him, and he's probably not very happy, and I just met him, so we'll see how that goes. But I partly reference Jeff, first of all, out of gratitude, right? Am I going to get it when I sit down again? Okay, good to know. But also because Jeff has already given me an important word, and that word is disruption. And that is what we need to do right now. We are far past the time of doing any kind of incremental change, and we got to just stop talking about it, people. And that's what we're trying to do, is create forums that catalyze the mojo that you all have in this room to become disruptors, because that's what we got to do. When I think about the healthcare landscape that we have out there right now, I have two questions in terms of the idea of getting reform. If not now, when? And if not Oregon, where? Okay, that's where y'all come in. So Couple things going to tell you real quick. Our next couple forums are going to be super cool. We are doing primary care on the brink, which we know it is here in Oregon, and we are going to do two-part series. The first one, Dr. German's going to come back and lend us his expertise, and we're putting together a dynamic panel to talk about some health to policy advancements in this area to see whether they folks think they're going to make a difference. The second one, I'm also extremely excited about. It is in person, April 7th. We're going to be up at that new campus in Northeast Portland that U of O has, and we're going to be talking to some disruptors. Two of them are Nick and Dr. Liz Powers out at Winding Waters Clinic in Enterprise, Oregon. I had the pleasure of being out there with them doing a big story. They have created an incredible hybrid model that they take basically all payers and then anyone from people who have nothing to big cattle ranchers who have a lot can walk in the door. They get medical, dental, mental health care, and on-site pharmacy all wrapped together. It's an incredible model, and we're going to hear from them and a number of other disruptors. That's going to be April 7th. OregonHealthForum.org is where the action is, and our amazingly capable program coordinator, Jen Gleiser, will be out by our table with our lit afterwards. We need to get merch and lit, right, just like they do at the shows. And then the last thing I'm going to say before I stop talking so we can actually hear from our panel is the Lund Report. So if you've read the Lund Report, you know how scrappy and independent it is. And by that, I mean sometimes it holds people's feet to the fire, right? How do I know that? Because I was at OHSU for 9 years in communications, and there were periods when we as communications professionals would cringe at the thought of what would be in the Lund Report this week about us, right? And also a lot of great reporting about all the good things OHSU does, but the point of accountability is to point to the solutions, right? And to appeal to our best selves to get there. And that's where we got to go, folks. So we too, copying on the City Club, are offering a special deal today on your table. There is a QR code, a little postcard. You can get a month free of the Lund Report. If you're not reading the Lund Report, you're not in it, people. Okay, all right. So I'm gonna stop talking and get John back up here so that we can move along. Thank you so much.
Now let's introduce our panelists for today. Rachel Prusak, a family nurse practitioner, is the executive director of the Oregon State Board of Nursing and a former state legislator. Jack Friedman is the chair of the Pacific Source Health Plans and former chair of SB 899 Commission, establishing Oregon's healthcare cost growth target. Tony German, MD, is vice chair of the Oregon Health Policy Board and medical director of Salud Pediatric Clinic in the Yakima Valley. And for a moderator today, Bill Kramer is a member of the Oregon Health Policy Board, a former member of the Congressional Budget Office Panel of Health Advisors, an executive director of health policy with the Purchaser Business Group on Health. Importantly, Bill is a longtime member and former treasurer of City Club. Today, our guests will discuss how recent federal legislation, rising costs, and unstable financing threaten health care access for all Oregonians, including threats to Medicaid, employer-sponsored insurance, and the marketplace. We look forward to hearing their thoughts on both short-term and long-term answers that will protect health care access for all Oregonians. Following their discussion, the panelists will provide significant opportunity for audience questions. During the Q&A period, questioners will be asked to line up on the side of the stage behind the microphone, which will be held by one of our City Club members. And we ask that you keep your questions under 30 seconds and have time to permit all others to ask their questions and participate. And make sure it is a question, a very short preamble, and a question mark at the end. Now, Bill, the floor is yours.
Thanks so much, John, and thanks and welcome, Erin. And thanks to all of you for being here on such a cold, rainy day. to hear this really important discussion. Shout out to City Club and Oregon Health Forum and Lund Report for hosting this event today. We have a tremendous panel today. As you heard in the introductions, they're not only experts, but also have strong opinions about stuff. We hope to hear from those today. And we have some diversity, as you heard, a nurse practitioner and former state legislator, and a primary care physician, and a health insurance executive. And so we'll get a variety of viewpoints and hopefully some good dialogue coming among the three of you. Just an outline. I'm going to provide a brief introduction at the beginning, just to give a level set, so we're all kind of working from the same fact base, including some recap of the very excellent session on February 6th that City Club and Oregon Health Forum hosted with Governor John Kitzhaber and Dr. Bruce Goldberg. If you haven't seen if you weren't there today or haven't watched the video, really worthwhile. Then we're going to have a conversation among the panelists and, of course, the Q&A with City Club members. So our goals for today's session are, first of all, to provide some information to you all from our panel of experts, but also to get a sense of where we could and should be heading. And maybe, if we're good at it, give some reason for hope that we can address the serious problems that we have in our healthcare system today. So let me start with a little bit of basic background information. First of all, about how people get coverage, how they get health benefits here in Oregon. First, the Oregon Health Plan, our state's Medicaid program, which for low-income people, which covers about a quarter of all Oregonians. We also have, of course, Medicare program, which is funded by federal government and payroll taxes. That covers about 17% of Oregonians. Nearly a majority of folks, just nearly half of folks in Oregon are covered by employer-sponsored coverage. People get their benefits through their employer. And then we have people who get coverage through the Oregon Health Insurance Marketplace, which is our version of the Affordable Care Act's health benefit exchanges. That covers about 6% of folks. If you add those all up, what remains is about 5% of people in Oregon are still uninsured, and many, because of the nature of the coverage they have, are underinsured. So where are we now, and where do we need to be going? Fortunately, Dr. Goldberg and Governor Kitzhaber provided some really good background information. I'm going to try to summarize that. First of all, they focused on issues of affordability of health care and access to coverage and access to providers. As Governor Kitzhaber said, the costs have been increasing in health care for literally 50 years. And this is not a new crisis. It's been a growing crisis for decades. According to OHA, the Oregon Health Authority, Oregon's annual per person spending on health care has increased almost 40% since 2015 and is now well over $9,000 per person. And these increases in health insurance premiums have consistently outstripped the growth in wages or the growth in general inflation. According to OHA's reports, as a result of these high costs, 15% of Oregonians, that's nearly 600,000 people, are delaying or avoiding health care due to cost. And 83% of Oregonians are worried about affording health care costs in the future. This is a serious crisis that affects many, many people, including many people in this room and around the state. The bottom line, health care is increasingly unaffordable for many Oregonians, as well as for employers and for the public programs that provide coverage. So Bruce Goldberg summarized the situation this way. He said, first of all, the way we finance healthcare is socially unjust and administratively complex. He says we have a healthcare system that focuses on sickness instead of health. He said that quality is incredibly unequal and that it's just way too expensive. So to make the problems worse, Bruce also pointed out that Congress passed a big bill last summer that's going to result in many members of the Oregon Health Plan and many people who receive coverage through the Oregon Health Insurance Marketplace to lose coverage. Governor Kitzhaber also pointed out that this is not just a problem in Medicaid, not just a problem for very low-income people. This is a problem that affects all of us, and therefore we all need to be part of the solution. One important thing also from Governor Kitzhaber and Dr. Goldberg is that they said in order for us to get out of this crisis we're in, we need a vision of where we're going. If we don't have a vision, then any road will take us there. We need a vision, get agreement on that vision, and then figure out what the pathway is to get there. Turning now to the discussion with panelists, I've asked them to attend to two major ground rules. One is I've asked them to frame their recommendations in a way that's meaningful to patients and consumers, not just for policy experts and industry insiders. And the other is I'm going to try to enforce, and this is going to be as much problem for me as for them, it's a no jargon rule. We want the conversations to be understood by everyone, not just those in the healthcare professions. So let me turn to the questions. As we said, it's important to start with a vision. And then we can talk about how to get there. So the first question, I'll ask each of the panelists to go in turn. What's your vision for healthcare for Oregonians in the future? And how will we know when we get there? Rachel, could we start with you? Great, thanks.
Sure, thank you. So first, thank you to the City Club and Oregon Health Forum and everyone who's joined. I'm honored to be here. It's a little ironic, but the last time I joined an Oregon Health Forum panel, crisis was also part of the title. And back then, we discussed the nursing crisis during the pandemic and had to meet virtually. Unfortunately, our healthcare system has been in crisis for a long time. And I actually believe we know how to get ourselves out of it, but we're going to need to be courageous and say all of the hard things out loud. So to answer your question, I'll keep it at a high level and then share more information when we dig in later. So at the end of the day, we should have nurses in every community across the state and country, period. In the US, about 60% of nurses work in hospitals and 40% in the community. And in all other countries, it's the other way around, with about 60% in the community. So to make this happen, we'll need to support nurses' full scope of practice and focus on community-based care and move away from our current reimbursement model. We also need to ensure that everyone has access to the basics of health coverage. Any day, any one of us can have our lives flipped upside down from an accident or a diagnosis, and when it happens, we need a healthcare system that supports us. We don't have that now, and when everyone has this access, that's when we'll know we succeed. Thanks.
Would you like to go next?
That's great. Well, thank you to the Oregon Health Forum and to Portland City Club for the invitation. Really delighted to join this panel and speak a little bit. Just clarity, speaking on my own behalf and not of the Oregon Health Policy Board or that of my organization. And I'm excited. I am really optimistic. We're at a forum for health crisis, and this is nothing new to anybody in this room, but everybody keeps filling these seats, right? And I think what we're doing is we're going to have an honest conversation. We're really going to start to look at, we're on the precipice of something coming, and we're seeing the car crash that we've been driving for a while. And many of us in this room have experienced in different ways, and whether you're in the healthcare or you're experiencing being a patient, we're finally seeing the curtain pulled back behind all the levers that we've put in place for a number of incremental reforms. And what I'm really excited about is looking at some new directions. And I think that there's more political feasibility of making some legitimate change now than we ever really have. And the reason behind that is because I've been looking at this issue for uninsured for a while and looking at different programs. Rachel and I were on the task force of the Bridge program. We've tried many different ways to arrive at that. But what we're finding is that right now we're looking at the point of 2,000 lives are going to be lost off of Medicaid. We're seeing the medical exchanges being totally disrupted because of how we've supported that. So I think that, looking at who's being more affected now, and I would just say that it's the broad scope of all of us. We are now seeing more of the middle class that's being impacted by employer and sponsored insurance. And I'm really excited about us looking and acknowledging the social contract that we have put in place. And we put legislation both federally and at our state level. When we look back in 1986 with the Emergency Medical Treatment and Labor Act, we acknowledged that we couldn't do patient dumping. We're not going to take a patient, we're going to put them over at that facility, and we're going to take care of them. Well, with that, we acknowledge is that we're going to have a hefty bill, and we're going to take care of you in the emergency department. And that's probably not the most effective way that we're going to treat you. We should be thinking about health. We shouldn't be thinking about treating disease. I would also call out in 2022 that we put in place in our Constitution a constitutional right that we're going to make healthcare affordable for everybody in Oregon. We've drawn some lines in the sand, and I think we need to acknowledge that the mechanisms and the tools and the programs that we've done, expansions of Medicaid, do the ACA, to put subsidization. I'm hoping that we can talk a little bit about some of the programs that we've done where we've done cost shifting and talk about how deductibles and co-pays and cost sharing are really impacting an individual. As a clinician, if I give somebody a hypertensive medication, I want to make sure that that's going to change their risk for hypertension or for a heart attack or a stroke. If a surgeon says that I'm going to give you this procedure, well, we better know that that intervention is going to make a change on the quality of life of that individual. We have not held accountability to health policy in the same way. And I think we're at a breaking point right now to see that this system is really breaking. It is about to collapse in front of our eyes. And it's no longer just impacting the uninsured and those on the lower. It is impacting all of us. And I think that that's the really big critical change that we're seeing for political feasibility for us to move. Now, what do I want to see in a healthcare system? Well, I want to see good health outcomes. The United States, as many of you know, is not doing optimally with regard to how other nations are doing it. I want to see a more simple system. And the reason why I want to see a more simple system is because I've got my colleagues are saying, peace. I'm not doing this anymore. I have had so many colleagues in my clinic with me that just can't do it anymore. They cannot continue to work in this perverse system that we continue to perpetuate. I think we need to draw back a system which the CCOs were, which was local contact and local control and attention to what we want to see in our communities, because you know best in your own community. Now we have directives and we have control of healthcare that's in other states. And we're seeing private equity and consolidation of care. And we need to pay attention to that, because that's also why we're seeing healthcare providers leave. Along with this is trust in the system. I think we really need to provide a healthcare system that people can really trust anymore. When I write a prescription for somebody, I'm not entirely certain they're going to get that medication. And when the patient comes back to see me in a month or two, and I ask them why they didn't do it, they're not only angry at the system, they're almost angry at me as a healthcare provider, right? And we can do better with that. And finally, what I think we want in a system, what is health insurance? It's a financial tool to give you security, right? And we have constructed this system that there is no security in here. 12% of us in this room will be uninsured this next month. That's the national statistics. Over 2 years, 1 in 4 of us will be uninsured. And the reason being is we're going to lose our job, we're going to change our job, we're going to turn 27, or circumstances are going to change. Sometimes many of my patients, they worked an extra shift and they're no longer at the thresholds that we have set in society for them to qualify for that benefit. And what has come with that is a significant amount of worry and anxiety and debt. It's mentioned about medical bankruptcy, but I don't think people really fully understand that 100 million people in the United States have medical debt right now. That's a big figure. 1 in 7 of us is in debt collection actively, okay? What that means is your credit scores are down. That means you have trouble getting a loan. That means you have trouble putting a roof over your head, you're in trouble getting a mortgage, getting a car. You might have trouble getting a job as a result of that because your credit score was reviewed by your potential employer. And the tremendous amount of worry that brings for everybody. I'm really optimistic because I think that there is a number of different good ideas that are coming forward. And we're going to talk a little bit more about the primary care sector, but I'm excited about how we're going to change financing in this country and really think about making some tough decisions. Many countries have taken different directions in really 3 paths. I think there is one that is really leading the state of Oregon, and that's with the Universal Healthcare Governance Board, which I think is doing tremendous work. And I think we should continue to pay attention to that body of work and the community members that are contributing to that effort. But what the United States has done for a long time is not take a pathway. We can regulate insurance heavily, or we can go to universal health care with single payer or something of that nature. And I think that that's really a strong direction that we need to be thankful. And I encourage people to learn about that. So that's where I think we need to go.
Thanks very much, Tony. Can I ask one question? You mentioned CCOs. Help the people in the room and those watching to run what CCOs are.
We're holding the healthcare system accountable and ourselves. I like that. Coordinated care organizations, which are the delivery mechanism for our Medicaid recipients.
Very much. Okay, Jack, you're up.
Well, I thank you very much. I'm feeling a little older up here, and I'm really glad to hear that you guys are as hopeful. I'm working on that. I've been at it a long time. You know, I just make a couple comments. The first thing I would say is I would like to see, beginning tomorrow, that the state stops investing a penny in detention centers and data centers and starts building primary care centers that are staffed by well-paid primary care doctors and nurse practitioners and PAs and MAs and everything under the sun, and nurses, Rachel. So that's the first thing I would hope that we could start doing, because we need that. Secondly, I would like to see us take 5 points of healthcare GDP, which is now at 19%, might be actually higher in our state, take it out of specialty and expensive hospital care and redirect it into education, housing, and food security. And I think that would get us a much better population outcome if we could get that done. I would like to see a much stronger regulatory presence on how we capitalize further expensive health care. It has been a free market. We have way too much redundancy in our hospital sector, and we need a much more aggressive state regulatory environment to manage that down. I would, you know, the Japanese are spending a third of what we're spending in this country, a third. And they're living on average 7 to 8 years longer. So we need to, I believe, just sort of give up on this employer-sponsored model completely. I don't even think employers want to be in this business anymore. They have no interest in distributing health care at their work site. They don't do it very well. And we need to move to a single universal fee schedule that is dictated by the state, somewhere between commercial and Medicare. I don't know what the number is, but it's not current commercial rates, that's for sure. And we have to build on what John Kitzhaber did for us 35 years ago and set a value-based benefit. Every other country except the United States makes really tough choices about what's covered and what's not, and looks at the population good for that. We don't do that here. Actually, in our country, insurance companies have to do that, and they don't do it very well. We need a single effort here. It has to be in the hour that we will have been here. Somewhere in South Florida, 17 people at the age of 98 or older have received total knee replacements. I don't want to deny them that if they can take the money out of their own pocket, but to publicly finance that when our children are getting into classroom sizes at the beginning of their lives with 28 other kids in them, that doesn't make a lot of sense to me. If an archaeologist came down to this country 300 years from now, after Trump has destroyed it, and looked at any hospital in this town to see where we put people for 4 days on average every 16 years, and then took a look at any K through 12, well, the 10 through 12s are getting better, but any primary or secondary school, and looked at the capital base there, they would say to themselves, what the hell were you people thinking? So we need a benefit design that is rational and affordable. We need a massive infusion of capital into primary care. We need to redirect expensive hospital-based specialty care resources and put it back into food, housing, and education. And then we need to do much better job of evaluating medical tech in the future and making hard, rational choices. John Kitzhofer told us this 30 years ago, but we haven't realized it yet.
Thank you, Jack. Rachel, really compelling visions. This might get short answers, but I'm going to ask the question anyway, because I think, Aaron raised the word about disruption. And the question is, looking at our vision, where you want to get in the future, can we get there with incremental change, building on our existing financing delivery systems, or do we need something to transform the system, to disrupt the system that we have now? And we'll get into more specifics in a minute, but just maybe it's a short answer, and let's go in reverse order. I'm guessing what. Incremental or transform?
I think, if we were starting from scratch, we'd abandon private health insurance and go to a single payer. I say that as a proud HMO executive retired. But we're not starting from scratch, and we have a lot of infrastructure baked into the current system. Personally, I've always liked the Medicare Advantage model, even though it's been a little rocky recently, I get that. But the MA model, I believe, offers two compelling features. The first is that government decides what the basic benefit is. They set the fee schedule for the providers, and they also set the capitation rate that is then laid off to the private sector. And they regulate the hell out of it. I can tell you that from past experience, and they should. Then the private sector, be it health plans, integrated delivery systems, whatever you want to call them, they accept the risk. They put in infrastructure as best they can to manage that risk, and they go out and compete. And if you look at the MA marketplace over the last 40 years, where now 58% of beneficiaries are now in MA. When I got into this business with my friend Phil Jackson out there, in 1988, our supplemental premium at the Providence Medicare Advantage was $35 in 1988. You can buy a product from them today for zero premium. So there is something working there. It requires a little bit of touch-up. I acknowledge that. But I think it separates nicely the role of public versus private, and we ought to build on it.
Incremental or transformative?
No incrementalism. I'll just be clear on that. I think I was trying to, and I'll be a little more explicit of that. I think that is evidenced by where we're at presently. We have arrived here because we've been following that path, right? I think we need to be honest with the steps that we're taking and using the tools we are. I think we really need to be disruptive. An example is, we did a lot of innovative and creative ideas in this state, and that is because that was what was politically feasible. And I really want to take this home is that I think we're at a big change in right now what people are going to see in the next year. And there is an uproar. There is more people excited about change than I've ever seen. And I've been, this idea of a single payer was like, oh my God, it's that crazy person over there, right? That's not how it is anymore. That is not how the majority of people, and, for looking at the midterms, this November, the number one economic issue for people is healthcare affordability. And I think that we're really going to see a strong change with that. So when we look at the Commonwealth Fund, so this is a surveillance of how we're doing, of what people are actually getting. Like, so back to what do we want to get? We want to get people the care that they need. So they need to get a medication, they need to get a treatment or a test, or they need to see a clinic, right? Where have we gone from 2010 to 2024? And if you review the Commonwealth Fund's evaluation of that, basically we started 1 in 5 individuals in 2010 were saying that they would skip their medications. 1 in 5 would skip a test or treatment. 1 in 5 would skip a doctor or their clinic visit. Now let's fast forward. Our own evaluation in our own state says that, and this is breaking down just a little more granular, and this goes to your question about insured and underinsured, which is a totally different term now, right? We really need to assess what that means, underinsured. So if you're insured, you're still skipping meds about 16% of the time. Your tests and treatments 1 in 5. For this is for an insured. For a doctor or clinic visit, it's 1 in 5. Where have we gone in the last 15 years with doing incremental reforms? Now, I want to take a quick look at underinsured. Now, the qualifier for this is saying the cost burden is that you're spending out of pocket after you've already paid your premiums in this system, okay? Is that you're spending 10% of your income as a cost burden, as a designation of that. There's also the distinction of catastrophic expense, which is 40% of your income. And what we see are those that are underinsured that are in this category where they have an insurance product. They've had these tools that we've gotten for income reform. We've put in the Bridge program. We've put in Cover All People. We've done expansion of Medicaid. We've done an expansion of the medical exchanges on the ACA. 3 in 10 people in this category are going to skip meds and or skip their pills or cut them in half. 4 out of 10 are going to not do the test or treatment that I would recommend them if they came to clinic. 4 in 10 of them are going to skip going to a specialist's office. So I would just say that where we arrived is we've tried this, and we can keep running against the wall and hitting our heads on that. Or are we really going to start to actually draw a line and say, we want these values, we want these outcomes for our community? And I think that the general public is starting to see the light, particularly with HR 1 facing them in the face. And I think people are rational decision making at this point.
I'll just jump in. HR 1 is the big budget bill from last summer, right? That cut Medicaid and the subsidies in the Oregon Health Marketplace. Rachel.
Okay, Bill, I know you said you want one-word answers of transformative or incremental, but these guys didn't do it, so I'm not either. Also, you said that, I know. Also, you said that we have a lot of opinions up here. I want to remind everyone I'm loving hearing all the opinions, but I'm here as a representative of somebody in the executive branch. So I say now I don't have opinions. I just have a lot of facts. But on this topic in general, so before I became a legislator, I thought we needed complete transformation, burn it down. I'd been a full-time nurse practitioner as a primary care provider, both urban and rural federally qualified health clinics for a decade, and it's why I ran for office. I wanted to bring the real-life experience of those of us on the front line to Salem. As a legislator, I saw that making incremental change was the only way to be successful. As chair of the healthcare committee, I led the charge on telehealth parity, and that attempt started before COVID, and I was told it was going to break the system, and everybody opposed what I was doing. Then COVID hit, and we passed the bill. It didn't break the system. I also led the charge to pass a bill for 3 primary care visits with no copay, and other things. But I want to say this now, after being a legislator, I will say, if our elected leaders at the state and federal level don't find a way to work with payers and systems to make the needed changes, the system's just going to burn down on its own. We're already watching the fire. As mentioned, primary care clinicians are leaving every day because of burnout and exhaustion, and I was one of them.
It's clear that we need big change. And there's some great ideas up here. So let's get a little more specific. Some of you touched on this already about some of the major policy changes. What would you recommend as a path to get from where we are now with the system burning down to where we want to get to. Heard some great terms earlier about trust and security and accountability and the appropriate role for nurses, community health centers. How are we going to get there? What are the big things over the next few years that could get us down that path? Why don't we go in reverse order again? You can start, Rachel.
Sure. So I want to share two examples of this. I want to share one with a perspective of my regulatory hat on and one with my clinician hat on. So I know that you mentioned things getting more and more regulation, but when I joined the Oregon State Board of Nursing, I posed this question to everyone. If regulations are the guardrails to protect the public, which ones genuinely protect the public and which ones are simply just barriers? And over the past 2.5 years, I led the board on identifying and removing outdated regulations that don't protect the public. And maybe the intentions were well-meaning, but after implementation, it didn't do what it set out to do. So leading the initiatives of 130,000 Oregon CNAs, LPNs, RNs, and APRNs, the places they work and receiving education, as well as recently serving on the Governor's Behavioral Health Task Force, where we look to identify administrative burdens, it's clear that excessive regulations imposed by licensing boards, CMS, state agencies, including Oregon Health Authority, are adding administrative burdens and increasing costs. So are regulations important? Absolutely. You were talking about some. But as regulations have grown in number and complexity, they've created administrative burdens that get in the way of actual care, which is burning us out on the front lines. I'm not going to go into examples of the regulations that I would suggest removing. My blood pressure would go up, you all's blood pressure would go up, and so it won't be good for ratings. But the solution for every system, state, and federal and agency is to review regulations and clearly separate the life-saving regulations from those that are wasting resources. And then I'll quickly put my clinician hat on and share another opportunity for solution. So research shows that investing in primary care lowers overall costs, improves outcomes, and boosts satisfaction for both patients and clinicians. In fact, Oregon's passed a law just last year, a while ago, to require OHA for Medicaid and DCBS for commercial payers to report how much spending goes into primary care. And while Oregon is ahead of many states in this country, in the bigger picture, we're just doing less poor than most. So I know part one of this series, the physicians really talked about how the doctor provides care, but today our primary care depends on a wide range of essential workers, the nurses, the behavioral health professionals, our social workers, our community health workers, all who work with a primary care provider who can be a physician, a nurse practitioner, or another independent licensed provider. And there are just so many examples that team-based approach reduces non-urgent visits. And so really, we need to make sure that primary care is the front line of healthcare systems. And if we don't reimburse better, the access will continue to decrease. Primary care providers and essential workers will continue to leave. And that's really the two things that I would say we have to do now.
Great, Rachel. Go to Tony, and I'm guessing you're going to have something to say about primary care. I'll just ask as we get here in the final few minutes of the panel to try to be fairly succinct so we have time for the Q&A from the City Club members here. So
Yeah.
go, Tony.
If we're thinking kind of more acute things, I think really that's we're very worried about our total spending and total cost of care. And as far as an intervention to actually deliver good quality outcomes, I think primary care really is it. I'm excited about that conversation next month. I encourage people to continue to stay attuned of that. I think we'll have more specifics of that. You know, as a vehicle of the work on the Oregon Health Policy Board, Bill and I just voted to move forward a slate, which is going to be the Primary Care Strategy Committee. We're thrilled by that composure of that group that's going to bring really some great insight to those next steps for us. We have done some great work in very creative spaces for the Primary Care Payment Reform Collaborative, but I think this is that next step in thinking about some of these issues as far as administration, how the impact of value-based care has really impacted the delivery of primary care broadly. We really need to focus on team-based care. You know, the recent recent study in the Milbank Foundation did a review and saw that, when you have a regular source of care, you're going to reduce hospitalizations by 20%. You're going to reduce ED visits by 11%. I can't think of a better, more effective strategy to improve people's quality of health than putting in primary care. With kids with chronic disease, those reduce by 50%. And so they also looked and saw that total healthcare expenditures in that place reduced by 54%. When we're staring down some issues as far as how much we're spending, and I think that that's a really key characteristic, and to really build up our workforce and bring in the pipeline, but also retain. So I think that that's really a strong focus for myself personally, and I think the state will really be leaning in on.
Okay. Jack, go.
We have to be quick. In a nutshell, if I could do this, I think the single best model we have in our state and around the country is Kaiser. Kaiser has a multi-specialty group practice where doctors actually talk to each other. They take a fixed amount of money every month called the premium, and they try to do the most good for the most people at the least amount of cost. That's the model that we need. So if we could replicate that model in the fee-for-service non-Kaiser world, create a value-based benefit design, have government set the capitation rate, and find other entities that can replicate what Kaiser has built over 80 years. That's kind of what I would like to see for our state. And I think if we could do that, we would bend trend and probably have money to reallocate to places that actually need it, like our kids and people that are hungry and don't have housing. If we could do all that, I think we get our population health metrics going in the right way faster.
Great. Thank you very much. I feel like we've just scratched the surface here, but hopefully have stimulated some good thinking among the group as well as among the audience. But we need to move on because we know lots of questions from the group here today. So I'll turn it back to John.
You are all welcome to ask questions. Please line up here. Please remember John Stride's instructions to keep your preface to 30 seconds and make sure that what you're doing is asking a question.
Oh, that's right. A question for Jack Friedman. I'd like you to define a little closer what you meant by value-based payments. There's a very bad interpretation of that, but if you're meaning using the priority list, that's one question. The other is indicate how we can make the best use of the MA model. Could the state have its own MA model with no other private versions? The private models have shown that they thrive only through cherry picking, lemon dropping, upcoding, and other perverse incentives.
Yeah, I agree with you on the perverse incentives in the private side. That didn't always used to be the case. But look, I would have a lot more confidence in having the state manage everything if I thought they could do it. But I don't. If you look at what public government has done to lower healthcare costs, they've only done one thing, and that's lower fees they pay to hospitals and doctors. That's it. They have never tried to manage the benefit. And they don't know how to manage utilization. So we need some entity that can go at risk for total cost of care. If we have infrastructure inside of not-for-profit health plans that can do that, and you want to redirect that into a central agency called the state of Oregon, then maybe we could aggregate and do all that. But I just haven't seen any evidence that our feds and any state in the country knows how to do that. And interestingly, starting 40 years ago, when the federal government, when 100% of Medicare beneficiaries were in traditional Medicare, the feds decided they didn't have the tools to manage utilization, and they started Medicare Advantage because they wanted to lay that risk off to an entity that could manage total cost of care. So we need to monitor the private better, but I'm not convinced that there is a federal or state infrastructure to do all that is necessary to control total cost of care, which, all right, I'm glad to hear that. I'd like to hear more.
Okay. Full disclosure, I've had both my knees replaced, but at Kaiser, so I guess it's good news and bad news. I asked this question last week last forum of Bruce Goldberg and John Kitzauer, so I'm going to ask it in a slightly different way. Their answers to it were visionary and brilliant and forward thinking. I'm more concerned about the immediate and intermediate future. And the question goes like this: what recommendations do any of the panelists have? I'm concerned about some of the statistics that Tony outlined at the beginning of his presentation about loss of access to care, the numbers of people that will be losing health insurance and access to services. What can we do in the immediate future to Trump-proof the system and offset some of the damage that's likely to be done in the next 3, 6, 9, or 12 months?
Great question. Let's give each of you a shot at that, because I think that's really important. We are facing a crisis right now, and people are suffering right now, and we're not going to be able to transform the system overnight, but there are things that could be done in the short term. What do you think? Go, Tony.
Yeah, I'll just jump in real quick, and it's probably going to piggyback what a lot of what Bruce said. But I think we need to leverage IT. What is being asked of the state is that you need to determine and demonstrate that you're working 80 hours a week, or volunteering, or having some sort of involvement that the feds will recognize for you to maintain eligibility for Medicaid. And this is really just a button clicking or making sure that paper is filled out entirely correctly. And I will say that speak to many of the tabletops and conversations. I believe that Oregon Health Authority is doing an excellent job of paying attention at this. But I think that if we can optimize the technology in our own health systems and our community-based organizations, that hopefully what we can do is navigate away from people missing forms not being filed. And I think that that's the largest bulk piece that we're going to be able to have an inroad on.
So it's basically to use technology and other processes to make it easier for people to enroll and re-enroll in the Oregon Health Plan.
Mm-hmm.
So, Tony, one of the things I think you said was about removing regulations, but also something that you said that made me think about is there's only 9% right now that aren't on the EHR system Epic, and so it leads to so much extra forms, so many faxes still, and so it made me think of that. But overall, I feel like I already answered this of saying there's an opportunity to make sure nurses are in the community, because this is how everyone does it, and this is how we keep people from being sick. So I will share that last year, Oregon passed in the legislature a bill to reimburse nurses. And I have been working as the executive director at the Board of Nursing with the Oregon Health Authority to understand the scope of practice of nursing. Nurses assess, care plan, monitor patients, education provided to patients. They're not just doing delegated tasks from doctors, but our billing structure has created this idea that everything we do, we've been told to do by a doctor, or, I'm going to say a nurse practitioner, but that is not how it works. So there is a bill that was passed, and we are working on implementation. I don't know when it will go live. I'm sure there will be barriers to it at first, but what it's going to do is finally take a model that has shown to decrease chronic conditions with the side effects going to the ER and actually getting care in the community, and flip our model on its head, as well as increasing reimbursement to primary care.
Great, thanks. Let's go to the next question.
Hi there. About 300,000 kids in Oregon are not reading at grade level. About 80 to 100,000 of those are estimated to have dyslexia, which is a brain-based learning difference. However, I say estimated because health insurance does not cover the cost of dyslexia diagnosis, which means that only parents who can pay out of pocket $3,000 to $6,000 can get a dyslexia diagnosis. We know that
Can you get to your question?
I can. Okay. So that we know that low literacy is correlated to depression, anxiety, dropping out of school, incarceration. And so my question is why aren't we considering literacy a public health issue and access to dyslexia a public health issue? We are, by the way, 50th in this country for dyslexia.
Yeah, I mean, I think that you're spot on. The reason we're probably not investing in it is because we spend way too much money inside of healthcare. At 19% GDP, that's basically $1 in $5. There's something very sick about any country that would allocate that much money to a single sector. So somehow we have to figure out a way to defund 5 points of GDP in healthcare and redirect it into primary care, education, housing, and food security. How we do that is not clear to me. But other countries have figured it out. Maybe we have to spend more time in Canada, Australia, Germany, and the UK. I don't know.
First of all, great job, panelists, and Jack, I do love you. I gotta say. So I guess my question is: you touched a little bit earlier, Bill, in your opening comments about the cost shift and what has sustained this very bizarre financing of healthcare has been the cost shift of government pay, which doesn't cover costs for most healthcare providers, to the commercial insurers and employers. And what I'm struck by is there really isn't an employer voice at the table, Bill, unless we sort of look to you as a PBGH leader. Do you think the healthcare reform conversation would go a lot further, a lot faster, if there was an employer at the table here saying, I'm done. I am done paying. I am done cost shifting. I'm throwing in the towel. And would the state be more attractive to employers if they didn't have to sustain the burden of the rising cost of healthcare?
I'll take a shot at this. I did work at the Purchaser Business Group on Health, which is large employers trying to manage their health benefits and do stuff through public policy as well. Employers, particularly small employers, are enormously frustrated by the current health insurance, health benefits system, and feel relatively powerless to do anything about it. There are a handful that are able to take a strong stand, particularly small employers are basically helpless. And many small employers literally cannot afford to offer any benefits. Those that can, it's usually a high deductible plan that means on the first $1,000, $5,000, $10,000 of expenses have to be borne by the employee. So it's enormously frustrating, and for their business and for their employees and their families. I think that what the employers are looking for is an alternative. What would the alternative be? And if there is a good option, I think a lot of employers, first small and medium-sized employers, and eventually large employers would be very attracted to that. What's missing right now in the current system is what's the option? If you're not offering health benefits now, some other company is going to offer them and will take those employees away. So offer an option. I think employers would go for it.
Bill, I was wondering if I could add a little bit on this. I mean, Bill and I were just on a phone call yesterday with somebody that's providing as an agent for employer-sponsored insurance. And those costs, they mentioned, over the last 5 years have gone up 20 to 40% for those employers. I'd like to put just a little more data on this. This is what I was mentioning about the breadth of the scope that we're seeing the impact on healthcare dollars and where this is going. It is no longer just in Medicaid. It is in employer-sponsored insurance. So the tool that we've done for cost shifting is to do deductibles so that you can make a premium more palatable, more feasible for an individual or a family to afford that. 20 years ago, those deductibles were fairly negligible. Now, for small businesses across the country, 53% are a high deductible for an individual. That's greater than $2,000 per year. That means you've paid your premiums, no access to care until you've paid that, and then you can get into that. And for a family of 4, that's $3,500 to $5,000 on average for that. So that is really cost prohibitive when most individuals, the median income for individuals in the state of Oregon is about $40,000. For a family of 4, that's just over $100,000. That's a big ticket item price, and that's leading to that debt. This is a math equation. It doesn't can you work. And I will make 2 bets with anybody in this room that healthcare dollars will be more expensive in the coming few years, and our premiums are going to go up.
Good bet. Phil, I would just add one comment if I could. I think that you raise a great point. I've been very surprised at how passive the employer community in Oregon has been over the last 10, 15 years as they've seen rising. I do think if we wanted to seriously talk about getting activation, we ought to consider eliminating the tax deductibility of health care, and more importantly, add it to your income at a certain level. If we wanted to make a big dent in the deficit, we would consider making employer-sponsored health care a taxable benefit. When people start paying for it that way, there might be way more activation.
I'm Richard Gibson. I'm on the Universal Health Plan Finance and Revenue Committee and the Transition Committee. I believe that the Universal Health Plan can solve a lot of problems, but there's some that are exterior to the Universal Health Plan. What is the appetite at the state legislature for eliminating the rent-seeking of pharmacy benefit manufacturers who do no value at all? And then also for private equity owning physician groups and hospitals. There's just no room to send that money off to shareholders when we need more care in Oregon.
Seriously, I will sigh like longer and louder. So again, it's why I went to the legislature. I wanted to do everything that I saw, watching our patients ration medication, and watching everything become too expensive. And so I took that on, and it's really, really, really hard. You have to have everybody on board, and the second you try to do a pharma bill or a PBM bill, you have dozens of the lobby in the building with fear tactics. The one thing that I was able to pass was something called the Prescription Drug Affordability Board. I don't know if anybody here is following it. If you're not, you can. Although I do think that maybe it didn't get off to the right foot. Again, we pass laws, but how they're implemented is what is important. And sometimes people forget to track that and track the implementation and speak up about it. But I think that is where we're going to be able to make a movement. And I know, because I was in the Capitol this week, that the Prescription Drug Affordability Board kind of paused going after pharma and towards prescription drug PBMs. I feel like everybody already said the word, so it's okay that I said PBMs. Okay, that's where it's at. That's where it's focused. But again, you have to have every legislator on board, or else it doesn't happen.
Tom Sinsick, I'm a retired family nurse practitioner. I was an early outer, because I got sick of prior authorizations and narrow networks that were causing tragedy among the patients. And so now I'm a disruptor, and I want to framework a couple of things. Health equity by 2030, that's in the state, right? A goal. Secondly, we have, Tony mentioned, right to health care in this state. Third, we've got the formation of ORS 751, which is the universal health care, which has a vision. The vision is out there. So keep looking at that document, please. And the fourth is what was just passed overwhelmingly in the legislature, HCR 202. Only 2 legislators in the whole state voted against it. So I want you to comment on the added of those items and how they all add up to say, we do have a vision, let's go forward.
Thank you, Tom. A lot of overlap. I think, from Senate Bill 1089 And I think with the initiative that I think Governor Kitzhaber is leading in trying to put in place a strategy, a direction, right? And I think that I was pleased to see that. And I think there is a growing political appetite to say that what is happening right now, we need to change our strategy. If we keep going in the trajectory we were going to find the same results. Now that is words on a paper. We need action. And with that, we need people really applying pressure. How does opinions change by legislators? It's by getting in front of them, talking to them, speaking up for the values and what we really want. And I think that on that piece of paper, the House concurrent resolution is an excellent piece. I would just say, again, I think there's a lot of overlap with the Universal Healthcare Task Force that actually has a plan, actually has a direction, can put the committees together and doing the hard work and making tough decisions and moving that forward.
The legislature loves to pass resolutions, only 2 no's, but we can't pass, regulations on PBMs. So there you go.
We have time for one more question. Sorry.
Oh, you're holding it? Good question. Good there. You know, in 1989, we started down the road of healthcare reform with John Kitzhaber and a group of employers and other people, and we put together the Oregon Health Plan, which was a really large disruptor in terms of the way we delivered care to the Medicaid patients. And it was intended to move on into the employer world. Small businesses didn't like that and didn't go anywhere. Now we're talking about a single payer system. And my question is, we now have an Oregon Health Authority that is attempting to destroy the Oregon Health Plan piece by piece. This last year, they put in a rule to get rid of the prioritized list. You know, when plans start.
Question, please.
Yeah, I'll get there. When plans started paying primary care more, they got rid of them. The question is what are you going to do to guarantee that the bureaucracy doesn't think that they know more than everybody else as long as they have more employees?
Totally fair question. I think that some of the constructs is that it's worked in a lot of other countries. A lot of other countries are able to solve this equation to say that public input, public presence, public pressure. I am of the opinion that, again, that when we're all in this together, when we have this contract, which we are, I mentioned before, I think we're already into. That I think when things aren't going right, I know like on the Oregon Health Policy Board, we hear a ton. I think the legislature would hear a ton. I think that those pressures is my belief that there would be accountability in that space. You know, I think that when we look at other utilities or other directions that goes, those function as a productive environment. And the honest truth is that there's nothing perfect. A lot of those other systems are incomplete, and there are changes that come. But what I would say is that if we are going to move towards something that's actually equitable and in getting coverage for everybody and making it cheaper, there is no doubt that those other systems, as we mentioned, they're cheaper, right? The other countries are doing it cheaper, and the patient satisfaction for a great deal of those communities is far higher than ours. If you look at Taiwan, who just really did the most recent development and change of that, they have the highest patient satisfaction as far as reviewing that. So I would just say the proof is in the pudding that, yeah, it's going to be hard, but I wouldn't leave that as the barrier to say, nope, we can't do that.
So we're going to be in a world of hurt real soon, and the crisis is going to be worse with HR1. I hear what you're saying about the Oregon Health Authority, and I watched the different things and the different debates, even though not being in the legislature. I think that we need to make sure that those leading the Oregon Health Authority are continuing to partner with those that are on the ground and on the front lines. And I think that when I was in the legislature, I was the only one of all 90 people that every day went into long-term care, that every day understood what the communities were going through, and I'm not there anymore. There are a few people there that are still clinicians. There are people there that care, but we need to, as a community, make sure that we have the right people in the legislature. We're constantly there talking to them and figuring out how they partner with the Oregon Health Authority to improve and keep moving forward.
Okay, tremendous session today. Thank you for your excellent questions. Thanks to Tony German. Thanks to Rachel Prusak. Thanks to Jack Friedman. Thanks to all of you. Hopefully we can continue this conversation in future sessions. Thank you.